Hello there, this is Dr. Mintz. Here's a chest radiograph that to me is very difficult. This is a perfect example of the kind of chest x-ray I see in portable chest x-rays and in some patients from the emergency department, and they can be very difficult. It's very hard to tell what's going on here. It looks like there's a central line. It's even real hard to tell exactly where that is. By the way, if you're having a hard time seeing central lines in some patients, although here you can see it quite well, it was a little difficult to distinguish from the median sternotomy wire, but you can see it's in the SVC. People tend to adjust the contrast to improve the visualization of the central lines, and that can help a lot too. But I find magnification to be very, very useful, something we really didn't have much of before the digital age. So use magnification, and you will see some lines that are very, very hard to see, and you just can't tweak it in terms of contrast and windowing, but zooming in will help. So here's a chest radiograph, and you look at it and you go, bleh, what am I going to say? This is all messy up here and some opacity here, and it's hard to tell. It looks like maybe there's some opacity here in the right upper lobe. Can't really see too much else. Zooming can't help for those things too. Don't see a pneumothorax or anything. They have had a central line placed. Well, that's a PICC line, I guess. Looks like it's a PICC line. So a lot depends on the history. If this is an inpatient and they're short of breath, could this be pneumonia? Yes. Could this be an area of pneumonia? Yes. Could there be some pleural fluid here? I don't definitely see any, but yes, there could be a little bit. This could be atelectasis or pneumonia down here. Very nonspecific. Could it be ARDS? Yeah, if the patient's been an inpatient for a while, it could be ARDS. Could be pulmonary edema related to failure. Not impossible. You can get asymmetric pulmonary edema, especially if it's in a patient that's been lying on one side, or if they have a lot of bullous changes in one lung, that can masquerade as an area of clear lung, while in fact it's just a lot of bulla that are preventing the edema from accumulating there. Could this be pneumonia? Absolutely. This could definitely be pneumonia. So you look at that and you think, well, I can't really narrow it down, but you describe it, and most importantly, you compare it with an old image. Now, let's look at the CT, and there's a pneumothorax on the right. And here the CT shows you that most of these opacities, particularly in the upper lobes, are posterior, which is kind of weird. Okay, why would that be? Well, let's take a look. Okay, everything seems to be mostly posterior here. Is there some pleural fluid there that's changed the windowing? Yeah, this is pleural fluid. I don't know what density that is, if that's blood or something else, so we'll take a look and get the density there. It's only 7 Hounsfield units, 7 or 8, so that's just simple fluid. How the pneumothorax came about, I'm not sure. There's a chest tube in place. Maybe that's how it came about. Probably not. So there's a pneumothorax, and you'd almost think, could this have been trauma? And I looked carefully at all the ribs, because usually if there was enough trauma to cause those pulmonary opacities, which in that case would be pulmonary contusions, you should have some rib fractures. Pretty much always you'll get some rib fractures if you have that severe degree of pulmonary contusion. But that's not the case here. So here's a good example of a difficult case, and even when you get CT, you can't narrow it down. I would say it doesn't look like failure, though, because you have these relatively confluent areas of opacity that have a kind of a peripheral distribution. Could these be septic emboli that have caused this? It's not a typical appearance, because septic emboli typically will show fluid in little areas of cavitation. On contrast enhancement, you'll often see enhancement in septic emboli. Pleural fluid related to failure is usually on the right before it's on the left, but that's not a hard and fast rule. Let's see what else we have here. Heart size really doesn't look big. Pericardium appears unremarkable. Just a good example of bad study that's just difficult to interpret, and a lot is going to depend on exactly what the history is and comparison with a prior study. Can make all the difference in the world.